To introduce our first speaker is Dr. Rochelle, who's an anaesthetist and a PhD student. She's going to speak to us on the topic of antimicrobial optimization in the peri-operative period. Rochelle is a PhD student at the university and a consultant anesthetist at the Sunshine Coast University Hospital. Her research interests include the pharmacokinetics of surgical antibiotic prophylaxis and dose optimization in the perioperative period. With that, we'll get Rochelle to start her presentation. Rochelle, you're good to go?
Thank you, Jayesh, and thank you for the invitation to speak tonight. Tonight, I'll break the discussion down into two parts. The first part, I will discuss why antimicrobial optimization in the perioperative period is important and really what our targets are. This will put into context some of the research we're conducting here in the group and also to define what we aim to achieve every time clinicians give prophylactic antibiotics in theatre. And in the second part, I'll use bariatric surgery population, which is a particularly at-risk group, to highlight some of the evidence and the contribution that our group has made to that growing body of evidence. So some background. Surgical site infections are an infection at the operative site within 30 days of an operation if no implant is placed. And the incidence in Australia, the reported incidence varies, but it's approximately 3%. And it's the most common hospital-acquired infection, so it's important. And what are the consequences if a patient gets a surgical site infection? There's consequences to the patient, to society, and also to a healthcare system. So for patients, of course, there's morbidity. So there's prolonged courses of antibiotics, possibly returns to theatre, and this comes at an emotional and financial cost with a prolonged hospital stay. And there's also an increased risk of mortality. The consequence for society, or the burden for society, is indirect costs in absenteeism and also to premature deaths. And of course, the impact on our healthcare system is quite great. There was a study done, which was a cost analysis study, and it was estimated that over $300 million per annum is the cost to the public health system in Australia, and that's due to increased length of stay due to surgical site infections. So surgical site infections have decreased, but they still remain a significant problem. And this decrease in infection rate is probably seen from not only on starting and improving antibiotic prophylaxis, but also in surgical technique. But we do still see that 3% incidence of surgical site infections. So is inadequate antibiotic prophylaxis contributing to surgical site infections? And can we use our knowledge of pharmacokinetic and pharmacodynamic relationships to reduce this surgical site infection risk further? When we administer surgical site infection prophylaxis, success requires that the therapeutic unbound concentration is reached in susceptible tissues against relevant pathogens, and that's for the duration of surgery. For surgical site infection prophylaxis, the most important PK/PD index is the time that the free antibiotic concentration is above the MIC90, and the most relevant pathogens are skin flora, and in particular Staph aureus. The susceptible time period for contamination is when the skin barrier is breached, so from skin incision to skin closure. And for most, but not all surgeries, we administer cefazolin to achieve this. And I'm sure this audience is aware that the MIC90 of cefazolin for Staph aureus is 2 milligrams per litre, and therefore this is the unbound concentration that we need to achieve in interstitial fluid of subcutaneous adipose tissue where these infections occur. And our current Australian guidelines recommend that 2 grams of cefazolin is administered for most surgical types, 15 to 30 minutes prior to skin incision to achieve these goals. If the patient is over 120 kilos, then we give 3 grams, and they recommend a second dose after 2 elimination half-lives are reached. So when I'm in theatre, I'm considering, is the dose I'm giving appropriate? Are we achieving those therapeutic concentrations exactly where we need it in that target tissue? Bariatric surgery is one of my interests, and this is a particularly high surgical site infection risk population. It's particularly important because obviously the incidence of obesity is increasing, and so we'll see more bariatric surgery occurring. There's no specific guidelines, or I should say the guidelines for bariatric surgery are the same for general surgery. So it's at 2 grams of cefazolin prior to skin incision, and then 3 grams if they're over 120 kilos. But are therapeutic unbound antibiotic concentrations obtained when we give this dose? There's about, I think it's up to 11 studies where we've looked at if the unbound plasma or interstitial fluid or adipose tissue concentration does reach target at skin incision and skin enclosure. But there's only 3 studies that's really looked and done compartmental pharmacokinetic analysis and Monte Carlo simulation to use larger simulated population groups to see if our targets are achieved. So the first study was by Brill et al., and they gave 2 grams of cefazolin to obese and non-obese patients and took unbound and bound plasma concentrations and also interstitial fluid concentration or measured interstitial fluid concentrations using microdialysis. The dark line that you can see is that the obese group, so obese patients undergoing bariatric surgery, and sorry, I just have to pull up my notes because the presentation mode wasn't working, so I'll just read them off a different computer. So the dark line is the morbidly obese patients undergoing bariatric surgery with a mean BMI of 47 plus or minus 5.8 kilograms per meter squared. And then there was normal patients with a grey line with a BMI of 28.2 plus or minus 2.8 kilograms per meter squared. The area under the curve for 0 to 4 hours was significantly lower in the morbidly obese patients in comparison to the normal weight patients, and the observed unbound cefazolin penetration ratio of plasma to interstitial fluid was 0.7 for the morbidly obese patients and 1.02 in non-obese patients, and this was statistically significant. And then they performed a Monte Carlo simulation, and these are the resultant probability of target attainments. The probability of target attainment of 2 milligrams per litre for the morbidly obese and non-obese patients actually wasn't that different in interstitial fluid and in unbound plasma, which is the graphs on the left and right respectively. If you look here at 2, a MIC of 2, for 4 hours, the PTA was 0.956 in the obese and 0.997 in the non-obese. But that did drop off with higher concentration targets. A further study by Gregor et al. Analysed the homogenized tissue samples taken at skin incision and skin closure for 117 patients, and they were given 4 grams of cefazolin, so quite a high dose, and a pharmacokinetic analysis proceeded, and they determined that the probability of target attainment of 2 micrograms per gram at 2 hours in the adipose tissue was less than 90% if it was a 2 or 3 gram bolus. But if you gave a 4 gram bolus or a 3 gram bolus plus a 1 gram per hour infusion, it increased to over 90%. This is different to the Brill results. So then our group conducted a study in bariatric surgery patients at the Royal Brisbane Hospital, where we gave 2 grams of cefazolin to 14 obese patients undergoing bariatric surgery. There was quite a large BMI range. So the median was 47 with a range of 36 to 69. And the weight was a median of 154 and a range there of 98 to 198. And on our left here, we have the unbound plasma concentrations. And you can see that for the time period, they were all above 2 milligrams per litre. And the microdialysis concentrations in the unbound interstitial fluid concentrations were also above 2 milligrams. The median concentrations, were above 2 milligrams per litre. There was a 4-compartmental model that was developed, and we then assessed the fractional target attainment and in differing BMI groups. And the fractional target attainment for 2 grams given within half an hour of skin incision resulted in the fractional target attainments of greater than 98%. This obviously increased as the dose increased. So I hope that data gives some insight into how we can use our pharmacokinetic analysis to optimise our dose for patients in the peri-operative period. The prevention of surgical site infections is very important, and the peri-operative optimisation of antibiotic therapy is essential as a part of a holistic strategy to reduce surgical site infections in our patients. There needs to be further research, of course, using the unbound concentrations in those target tissues to really optimise our doses in different surgical subtype groups. Thank you.
Thanks, Rochelle. That was a lovely presentation. Actually, I certainly have a few questions for you at the end, so stand by.